I think we still have a few people coming in.
Kemi, would you like to get started?
Kemi, sorry, I think you're on mute. Good morning, everyone. Sorry, I didn't realize that. Thank you for joining us today. We are pleased to welcome you to a Realizing Healthier Pregnancies research cluster. We are so happy that you were able to join us today. My name is Kemi Amodu. I am an assistant professor in the Faculty of Nursing at the University of Alberta. My work focuses on sociocultural causes of health disparities for women and children and seeks to ensure that maternal health programs are more inclusive of marginalized women. I'm very pleased to serve as the session moderator today. On behalf of WCHRI, thank you for taking time to attend this session. Before we get started, I would like to do some land acknowledgements. Bear with me here. Can you see my screen okay? So the University of Alberta acknowledges that we are located on Treaty 6 territory and respects the histories, languages, and cultures of First Nations, Métis, Inuit, and all First Peoples of Canada, whose presence continues to enrich our vibrant community. I would also like to thank WCHRI's funders, the Story Children's Hospital Foundation, and the Alberta Women's Health Foundation for making this research cluster possible. So let me also add that WCHRI is actively seeking to build this research cluster. Please reach out to WCHRI to join the cluster and to nominate your collaborators or networks. WCHRI's email is in the chat, and Michelle Balo will stay in the session to answer any questions you may have about the participating in this cluster. Just a note that the session will be recorded and posted to the WCHRI website, and WCHRI will send out the link in about 24 hours after the session. I encourage you all to ask questions and actively engage. Feel free to share your thoughts in the chat box or to raise your hand if you'd like to contribute after the session. And without further ado, I would like to introduce Dr. Marilyn Ahan, an assistant professor in McGill's Department of Medicine and a junior scientist at the McGill University Health Center Research Institute. Dr. Ahan examines the mechanisms through which parental mental health and parenting behaviors influence child development and mental health in global contexts. Her current work on maternal, paternal, and child health research in Ghana is supported by a Treasure Research Fund Early Career Award and the Victoria S. Levin Award for Early Career Success in Young Children's Mental Health Research from the Society for Research in Child Development. Dr. Marilyn Ahan, you're welcome. Please take the floor.
Thank you very much, Dr. Kemia Modu, for that lovely introduction. So let me share my slides and make sure you view. Are you seeing my slides as they should be? Great.
Yes.
Well, thank you so much, Dr. Modu, Michelle, and Carrie, for inviting me to speak today. It's really a pleasure for me to be here. And I'll be talking to you today about my work on parental mental health, parenting behaviors, and young children's mental health in Ghana. Before I begin, I also want to acknowledge the land that I'm presenting from. So I'm based at McGill University, which is situated on the unceded traditional territory of the Ganyangahaga, who are a vibrant community and one of the founding nations of the Haudenosaunee Confederacy. And I encourage all of you to commit to taking action to support the ongoing resistance and thriving of local Indigenous communities wherever you may be based. So today I'm going to start by giving you a general overview of how I got to where I am, as I always think it's interesting, when listening to people present their research to know what brought them to where they are. Then we'll spend the bulk of the time talking about children's mental health in Ghana, what we already know and what we don't know, what my research collaborators and I did in this particular study, what we are finding, and in addition to what's next. And I then end with a brief discussion of ways that we can move this type of research forward generally. I will add the caveat before beginning that these findings are very preliminary. We haven't published these yet, and so I kindly ask that if you do take any pictures, that you don't share any of these slides publicly. Thank you. So I began my academic journey right here at McGill during a bachelor's in honors psychology, where my interest in maternal and child health really began. And so I was able to travel to Ghana to study how maternal depression specifically was associated with children's cognitive development. And this really sparked my interest in understanding the importance of parental mental health and how it impacts child outcomes. So I then decided to pursue a PhD in public health at the Université de Montréal, where I further examined these associations by identifying mediators and moderators of the association between maternal depression and children's cognitive development, using data from a population-based cohort right here in Quebec. During this time, I also had the opportunity to collaborate with researchers in Ghana, Kenya, and the US to design and evaluate parenting interventions and examining their impact on child outcomes. During this time, I really had an interest in interventions. I wanted to learn a lot more about them, and so I decided to pursue a postdoc in global health, where I particularly focused on the implementation strategies of early childhood development interventions in global contexts, trying to understand how these programs were being implemented, what factors were more efficient or effective in improving child outcomes and parent outcomes as well. I also had the opportunity to collaborate with colleagues in Lebanon and Ghana to examine associations between parental mental health, parenting practices, and child outcomes. So throughout this journey, what has really driven my work and what drives my current research program is the DOHAD hypothesis, which really focuses on the importance of examining the early childhood environment to better understand the etiology of chronic health problems in adulthood. And I'm sure, given your interest and your presence here, that we all understand the importance of this environment. So not just focusing on the prenatal environment or the uterine environment, but really up until the first 5 years of life, the experiences that children have in this time can really shape their later outcomes. So within this context, I primarily focus on mental disorders as they are among the chronic diseases associated with the largest number of years lived with disability, with many mental disorders having their onset in childhood, and 13 to 20% of youth experiencing mental health problems. So within this context, I particularly focus on global context because of the 90-10 research gap. So this is basically the finding that although 90% of the world's children live in low or middle income countries, only 10% of research comes from that context. The other 90% is primarily focused on high income countries, and not at all in diminishing that important work that's being done. But what I hope to do in my work is to really expand the field of child mental health research to ensure that we are understanding the context that all of the world's children live in and identifying ways to improve and promote their mental health. So within the context of all of this background, the overall aim of my research is to identify the mechanisms through which parental mental health and parenting behaviors impact child development and mental health in global contexts. I'm currently working towards this through two different axes. The first uses observational research to identify mediators and moderators of the association of parental depression, so focusing both on mothers and fathers, with child development and mental health. The second uses intervention research to design, implement, and evaluate interventions that support caregivers to promote children's development and mental health, as well as overall family well-being. So the study I'll be presenting to you today primarily focuses on the observational research axis, but as you'll see towards the end, its aim is to generate preliminary data to help inform the development of an intervention further down the line. So now let's move on to what we know and what we don't know about children's mental health in Ghana. And I'm going to start with a much bigger, broader view on what we know globally about children's development. So in 2016, a study was conducted that tried to estimate the number of children around the world who are at risk of not meeting their developmental potential. And this was estimated to be about 250 million children worldwide, with the majority of these children living in low and middle income countries. And we know that this really has a detrimental impact on children's lifelong mental and physical health. And within this study, they defined the lack of or not being able to meet their developmental potential in a particularly narrow way. So they used estimates of the number of children exposed to poverty, or the number of children who were stunted, so being shorter, having a shorter height for their age. But we know that exposure to various biological and psychosocial adversities in early childhood increase risk of poor development and mental health problems beyond simply poverty and stunting. So the Lancet commissioned series in 2017 that try to summarize what we know in science about early child development identified 4 key risk factors within this period. They included delivery by an unskilled birth attendant in the home, exposure to infections such as malaria and diarrhea, inadequate nutrition, and inadequate psychosocial stimulation, which is a relatively broad term that primarily consists of parenting practices. So how well and how often parents are talking with their children, playing with them, and stimulating their minds as they grow. And so based on this research, the general conclusion was that children need to grow up in a nurturing environment in order to mitigate the impact of some of these adversities. And in this context, nurturing care has been defined as the core set of interrelated knowledge, practices, skills, and behaviors that enable optimal caregiving for children's health, nutrition, learning, behavior, secure attachment, and safety. And so from this, the nurturing care framework was developed through a collaboration with the WHO, UNICEF, and the World Bank. And they identified 5 core components of nurturing care that every child needs in order to thrive. And so these primarily focus on having good health, adequate nutrition, responsive caregiving, growing up in a safe and secure environment, and having opportunities for early learning. So given this general background of what we know in the world, I'm now going to zoom into the Ghanaian context specifically. So for those of you who don't know much about Ghana, this is where it's located. We're in the western part of Africa, and it's a lower middle income country that gained its independence from the British in 1957. And despite its relatively small physical size, it has a large population of over 34 million, with children under the age of 15 accounting for 40% of the population. So it is a relatively young population, and trying to understand the context and the health of children in this environment really has important implications for the future growth of the country. So Ghana has a relatively high rate of pre-primary enrollment in the sub-Saharan African region, with over 90% of children being enrolled in pre-primary education centers. However, the Human Capital Index is estimated to be 0.44, which generally means that children born today are expected to only reach 44% of their developmental potential, meaning that their exposure to various risk factors in their early environment are diminishing their risk, their chances of being able to live a full and healthy life. So in 2017 and 18, the UNICEF mixed study was conducted, which is the Multiple Indicator Cluster Survey. And it estimated that about 44% of 3 to 4-year-olds in Ghana are developmentally on track for literacy and numeracy, which is a relatively small number. And what is not quite seen here, but I wanted to note, is that there are a lot of disparities in terms of rural versus urban areas, in terms of maternal education levels. So there are really a lot of children within Ghana who are not reaching their expected targets given their age. When it comes to mental health problems specifically, various studies have estimated prevalence rates of mental health problems in school-age children, so from ages 6 and above, from 4 to 23%. And they've identified risk and protective factors for various mental health problems, including children's suicidality and emotional problems. So for example, peer victimization and food insecurity were identified as risk factors for suicidality and emotional problems, whereas family support and parental understanding of adolescents' problems and worries were identified as protective factors for depressive symptoms and suicidality. So despite this burgeoning research on children's mental health in Ghana, no study has examined the mental health of really young Ghanaian children, so children who haven't yet entered the primary school system. The only available data that we have in the country is on socio-emotional development in 3 to 4-year-olds, which comes from this 2017-18 mix that I referenced. So these data are based on the Early Childhood Development Index, which is a very useful but ultimately flawed population-level measure of child development. So it consists of 10 items that are caregiver reported. In most cases, it's the mother who reports it. And it defines children as being socio-emotionally developmentally on track if 2 of the following 3 sentences are true. So that the child gets along well with other children, that the child does not kick, bite, or hit other children, and the child does not get distracted easily. I'm sure for those of you who are child mental health researchers, you'll know that there's a lot more to children's socio-emotional development and their mental health than can be captured by these 3 items. And so based on these 3 items, the mix showed that 67% of Ghanaian children are developmentally on track, which is great, but we definitely need more nuanced data on children's socio-emotional development and mental health if we want to act to improve child outcomes. So given this context, we decided to conduct a study in southern Ghana with about 750 families. And our primary objectives were to determine the prevalence of mental health problems in children below 5 years or younger, and to examine family-level psychosocial risk and protective factors associated with children's mental health. So as I mentioned earlier, these data are quite preliminary, and so the data that I have available to share with you today are primarily related to Objective 2 on examining risk and protective factors. I want to acknowledge that this study was funded by the Thrasher Research Fund and was done in collaboration with Dr. Richard Appiah, who's a senior lecturer at the University of Ghana, and David Jani, who is the primary implementation coordinator for the study. So we primarily targeted adult parents of a child between the ages of 6 and 60 months who lived together in the same household with the child. So because we wanted to understand how parental characteristics impacted child outcomes, we wanted to ensure that families were living together as part of our inclusion criteria. Data collection occurred from December to February of this year in the Ga South District, which is a semi-rural area about 30 kilometers west of Accra, which is Ghana's capital. So as I said, we sampled 750 households and we interviewed mothers and fathers separately. And so overall, there were 1,500 mothers and fathers. So for both mothers and fathers, we asked them about their individual and household characteristics. We assessed their depressive symptoms, their positive mental health, as well as parenting practices, so the different ways in which they interacted with their child. Then for children's mental health outcomes, we only asked mothers and we used 3 different measures. So we used the Ages and Stages questionnaire, which enabled us to compare outcomes across all ages from 6 to 60 months. Then for younger children, we used the CREDI, which is the Caregiver Reported Early Development Instrument, which is a caregiver reported measure that was developed by a team at Harvard in collaboration with the World Health Organization to be a universally acceptable and used tool to assess children's various dimensions of children's development, including their socio-emotional development and their mental health. And then finally, for slightly older children, for 37 to 60 months old, we used the Strengths and Difficulties questionnaire, which is a widely used measure in the field. So overall in our sample, children were about 31 months old, and it was evenly split between boys and girls. And almost 60% of children had been sick in the past 2 weeks, with the majority of them experiencing respiratory illnesses. 98% of female caregivers were the target child's mother, and they were on average 31 years old. About a third of female caregivers had no or only primary schooling, and 70% of them worked outside of the home. Similarly, for fathers, the overwhelming majority of them, of male caregivers, were the child's father. And a fewer proportion of them had no or only primary schooling, but more of them worked outside of the home compared to female caregivers. And overall, the average household size was about 5 people and with a monthly income of 160 Canadian dollars. And I do want to add the caveat that it's really hard to interpret this monthly income variable because it varied widely, not only across households, but also within households. So, if a family was making $200 in one month, they might be making $50 in the next month. And so it's a variable that varies a lot, as you can see from the standard deviation there. So to give you an idea of how this particular sample compares to the rest of Ghana, I'm comparing it using data from the most recent demographic and health surveys, which was conducted in 2022. So in our sample, we had a higher proportion of children who had been sick in the past few weeks, fewer mothers and fathers who had no or primary schooling compared to the rest of the country, and our average household size was slightly larger than the rest of the country. So in terms of our analyses, we conducted univariate and multivariate linear regressions to test the associations between a variety of family psychosocial factors and child outcomes. So here I'm presenting the results separately for children's age. So I'll first present the results for 6 to 36-month-olds, and then the results for 37 to 60-month-olds. So one thing to note here is that for the CREDI, higher scores indicate fewer child mental health problems. So it's better to have a higher score. And we can see here in unadjusted univariate regression models that maternal negative discipline, maternal positive mental health, and maternal depressive symptoms were all moderately associated with children's mental health outcomes. And we found a similar pattern for fathers, where the negative discipline, positive mental health, and depressive symptoms that were associated with child mental health. Once we adjusted for parental education and employment, household income, and child sex, only maternal positive mental health was still associated with children's mental health outcomes, suggesting that the experience of positive mental health, so feeling connected to one's society, feeling that one belongs, feeling that one has a purpose in life, was the strongest predictor or strongest factor associated with children's mental health outcomes. We tested for the interaction with parental education, but did not find a significant association. And then now presenting the results for slightly older children, I want to point out that here for the SDQ, higher scores indicate more child mental health difficulties. So higher scores indicate worse mental health. So again, focusing on just maternal outcomes, we see that all aspects of maternal parenting and maternal mental health were significantly associated with children's mental health. But for fathers, it was only their use of positive discipline strategies, such as distracting the child or explaining to the child what they had done wrong, as well as their mental health, that were associated with children's mental health outcomes. Once we adjusted for our covariates and included all of these in a single model, we only found this significant interaction between maternal positive mental health and parental education to be associated with the outcome. So specifically what we found was that maternal positive mental health is only associated with older children's mental health and families where both parents have higher levels of education. This is a really interesting finding because in another study that I'm currently trying to publish, we used data from an intervention that was conducted in northern Ghana, and we again found moderation of associations between parental mental health and child outcomes based on parents' level of education, suggesting that this factor really plays an important role within the Ghanaian context. So in addition to these preliminary analyses, our hope for the next steps are to identify contextually appropriate cutoffs for the child mental health measures using receiver operating characteristic analysis and conducting moderated mediation analyses. So as, the other study that I just mentioned was a mediation model where we looked at the extent to which parenting dimensions mediated the association between caregiver psychological distress and various child outcomes, moderated by caregivers' education level. And so the aim is to replicate those similar analyses using these data. We also want to identify the status and correlates of other child development dimensions. So beyond children's mental health, what are some other factors that are impacting children's cognitive and language and socio-emotional development, and really trying to identify whether maternal positive mental health is really still the key factor, or whether we might see that it's more maternal mental illness, such as depressive symptoms, or other paternal characteristics that are more important for other dimensions of child development. We're also working to disseminate these findings to community members, policymakers, and other child and development mental health researchers in Ghana to think of how we can use these findings to better support families of young children in this context. As I mentioned earlier, this study is really a preliminary study to inform the development of a future intervention. And so one of the projects that I'm currently working on is to inform the design of a multi-component parenting and mental health promotion intervention to improve early child development and parent outcomes. And this work is being funded by the Society for Research and Child Development. The specific objectives here are first to conduct qualitative interviews and focus group discussions with parents and other caregivers, because in many contexts and communities across Ghana, parents aren't the only two individuals caring for a child. Usually extended family members and other community members are involved in caring for young children. And so we want to be able to include their voices in developing this intervention, as well as broader community members, including service providers who support parents of young children. And the aim here is to better understand how young children are cared for and how parents take care of their mental health. And the reason we're using this qualitative approach is really to better understand what is the current context, what are parents currently experiencing, and what's the support that they want? What is it that they would like to receive from their local health services or community services, and then using that information to then build out a service that addresses those needs. So once we've conducted these qualitative interviews and focus group discussions, we're then going to use the learnings from that to adapt two existing intervention curricula. One is the Inspired Life program, and the second is the Responsive Parenting program. And I'll talk a little bit about both of those later on. And then once those have been adapted, we will then test their feasibility and acceptability, of then moving on to test their efficacy and effectiveness And if those work well, then looking at how we could scale up to support as many caregivers as possible. So the Inspired Life program is a 10-week group-based positive psychology intervention that focuses on mental health promotion in adults. And it was designed by my colleague, Richard Appiah, in rural Ghana. And so it was designed specifically in the Ghanaian context. And in a quasi-randomized control trial, he found that the intervention successfully improved mental health and reduced depression symptoms in adults living in rural Ghana. And so there's promise there that it could also lead to improvements in mental health outcomes for parents. And the second program is the Responsive Parenting Program, which is a 6 to 8 month group-based parenting intervention for parents of children younger than 3 years old. And it focuses on 5 key practices for parents to engage with their children. So engaging in responsive play and communication. So this means that the child being responsive to the child's lead and the child's interest in different activities, rather than the parent being the one to lead those interactions. Hygiene, nutrition, and love and respect in the family, which is a relatively broad term that focuses on aspects such as communication between the caregivers, the experience of domestic violence, and engaging in gentle discipline with children. So this intervention has been tested in Uganda, Kenya, and Bangladesh using cluster randomized controlled trials, and they have consistently found improvements in children's cognitive, language, and socio-emotional outcomes, as well as in parenting practices. There's less consistent evidence on its impact on parental mental health, and it has previously been used in Ghana, but its effectiveness or efficacy was not formally tested. And so that would be our aim in merging these two interventions together to test how impactful it is in improving child and parent outcomes. So just want to thank you all once again for your attention. I'm very happy to take questions. And if you'd like to learn more about this study or some of the other work that I'm doing, please don't hesitate to reach out. Thank you very much.
Thank you so much, Dr. Marilyn Ahan. That was a very beautiful presentation. We're so happy to learn all these wonderful interventions and potential scaling up of strategies that you're working towards with your team. We will welcome questions from the audience. And yeah, if you can raise your hand or keep it in the chat box, it would be appreciated. Thank you. I think we have William.
I'm about trying to get my picture on here so you can get scared. Oh, there you go. I want to echo what was just said. That was really a nice presentation, thoughtful and crafted in a way that even a non-clinician like myself can easily recognize where it is that you've been and where you're heading. And I'll try to make this as brief as I can, but I was so captured by what it is that you're focusing on, which seem like it seems like the most logical and feasible actually way to try to develop some feasible and practical intervention. So I have a tiny another modifiable risk factor that you've made me now think of in another way, which is sleep health. We think that, as you probably have also thought about, that it's a modifiable and mediating factor, or rather a moderating mediating factor for so many negative outcomes, from emotional health to growth to immune function to cognition, etc. But I never realized before, in particular, one of the your findings was, I think it was somewhere in the neighborhood around about 50% of the kids had some sort of a respiratory problem within the 2 weeks of when you did your assessments, which I didn't know about, and which is a really big, obviously, effect, but maybe a modifiable one, both for helping better ways to treat those, but also the effect those respiratory illnesses have, as we all know, and we've had everything from a cold to a flu. Our sleep health is one of the first things to go by the wayside. And I just can't help but wonder how much of an effect that also is in I guess influencing the other factors that you're looking at as well. So I'm sorry that was such a long question, but mainly I want to convey that I'm happy that you gave us this information and wonder if you've thought about sleep at all.
Thank you very much, William, for that very great question and the interesting commentary around it. So I will first clarify that we did look at associations between having had a respiratory illness or some kind of infection in the past 2 weeks and children's mental health outcomes, and didn't find an association in this sample. But I will acknowledge that usually that is associated more with children's cognitive and language outcomes, because when children are sick, they're less likely to want to play or to engage with others, and adults are also less likely to engage in play and in communication with them. And so we do tend to find a stronger association with cognitive and language outcomes. So once we test those particular outcomes, that will be an interesting factor to look at. I hadn't connected any of this to sleep, but as somebody who very much values my sleep and ensures that I get X amount of sleep each night and to function, I know just how important it is and how big of an impact it can have on physical and mental health. And so I think looking at the intervention content, that could be a really great way to try to bring that in looking at sleep habits and sleep practices that caregivers have with their children, and looking at how we can perhaps try to improve that or target that as another way of trying to improve the early childhood environment of the young children.
Thanks very much.
Yeah, thanks for that response. William, were you going to ask a follow-up question? I think I saw your hand.
No, I wasn't, other than to say that I meant to fix my name. It's Bill. I hope to attend a lot of these. It's not William, but well, it is, but it's Bill.
Nice to meet you, Bill.
Dr. Marilyn, actually, I did have a question for you. As I was listening to you, I think in the beginning phase of your presentation, you did mention that a relatively high number of Ghanaian kids attend pre-primary education.
Mm-hmm.
That is like an interest area for me, because I've always wondered in terms of research, how does attendance in formal daycare settings impact early childhood development and mental health in children in this kind of context? Have you or your team thought about that, or even looking at what the impacts might be in terms of just how the caregivers contribute to the mental health challenges that children might have growing up?
That's a really great question. So I personally don't do a lot of research in early childhood care and education, but I have a lot of colleagues that do. The data that I'm aware of mostly comes from the Canadian context. And generally, we know that attendance in early childhood care and education settings does lead to improvements in children's cognitive and language outcomes, but there's mixed evidence on its impact on children's mental health outcomes. And so it's not necessarily a given that attending early childhood care and education leads to improvement in children's mental health outcomes. Globally speaking, I'm not as aware of what the direction of those associations are and how much research has been done in that area. So I definitely think that that's an area that needs to be further explored. And generally in the early childhood care and education space, what I know some colleagues are trying to focus on is beyond attendance, what is the quality of the services that children are receiving? Because, it could be that the children are, yes, they're attending these services, but they're just going to sit in a room and their toys, and they don't interact that much with the adult that's supposed to be caring for them in that time. So attendance is one thing, but really trying to understand what's the quality and the quantity really of the services that children are receiving, and trying to look at how that impacts child outcomes, I know is a particular question of interest in that area.
Yeah, absolutely. Yeah, because when you think about just how caregiving is impacting child raising experiences, that definitely would have to consider the impact or the contribution that caregivers are making outside of the home. Because if children are spending so much time outside the home, then it's important to see how that might be impacting their development as well.
Yeah, that's a really good a really fair point, an interesting point there. Of course, the amount of time that children are spending outside of the home also varies a lot depending on their age. So, a 7-month-old might not be spending as much time in early childhood care and education as a 40-month-old, for example. But that's a very good point. It's definitely an important part of the early childhood environment, and we need to better understand how that contributes to impacting child outcomes.
Also, just in terms of, I was also thinking in terms of the cultural dynamics within the Ghanaian context, just as you rightly mentioned that some of the instruments that exist to measure childhood psychosocial milestone achievement might not necessarily be inclusive of that context, right? I wondered how the culture in Ghana, just as it relates to disciplining of children, might vary compared to the mainstream or the global agreed upon methods that are used in the literature. I just wondered if you may have considered looking at that variation in terms of how discipline looks like, for example, here in Canada and in Ghana, and how that might impact outcomes.
That is a very interesting question, and I feel that there's sort of two levels to that. So one is the validation of measures across different contexts. So the reason we used 3 different measures to assess child mental health was partially because of that, and that not many measures have been validated in Ghana before, so we wanted to have a variety of tools. And we specifically chose the CREDI, the Caregiver Reported Early Development Instruments, because Ghana was one of the sites in which the tool had been developed and validated. And so we knew that it had already been used in the Ghanaian context, mostly in northern Ghana compared to the south, but it was at least more culturally similar to the Ghanaian context than the other 2 measures that we had. In terms of the discipline measures, so those were assessed using items from the Multiple Indicator Cluster Survey, which is a global survey that UNICEF conducts around the world. And so these items have been specifically selected to be applicable to various cultural contexts. And on that note, I think it's important to highlight that, so there's a colleague of mine, Jorge Cuartas, who does a lot of really great research on violence against children. And it's been shown time and time again that any form of violence against children is detrimental for their mental health, whether it's, smacking all the way to beating them up. Any form of violent discipline is detrimental for children's health. And so although cultures might vary in their acceptance of the level of violent discipline or what's deemed as being normal in terms of how children are disciplined, we know that it is detrimental for child outcomes. So that's why I wanted to include it in this particular study. Because it was a quantitative study, we didn't ask parents about their what they thought was an acceptable way to discipline the child or not. But it is worth noting 2 things. One, that there might be a social desirability bias where even if it might be culturally acceptable for parents to discipline their children using more physical strategies, let's say, they might be mindful of, well, there's this team from the University of Ghana coming to ask me about how I take care of my child. So they might be less willing to share honestly how they discipline their child. And also there are laws in Ghana protecting children and specifically enshrining children's right to not experience violent discipline. Whether that law is enforced is a whole other question, but the law does exist. So, there might be what is culturally acceptable, but then there are also legal factors to consider. And so it's a very interesting question, but yeah, those are just some key points I wanted to highlight in response to that.
Thank you, Dr. Marilyn. This is very, very, very insightful. I welcome questions. I also kind of think about the competence of medical providers that see these families in terms of how they're able to diagnose some of these psychosocial issues. I know that I've had conversations with medical colleagues who have mentioned that there is an increasing sort of diagnosis going on with immigrants to Canada, where we see like a lot of children are diagnosed with, for example, autism. And there's the conversation that could this be a result of having overdiagnosis, just because we have all that capacity in North America? Do we have the same kind of incidences going on in children that in the Guinean context, or, is this something that, health providers are knowledgeable about, in terms of just being able to have this as a part of their assessment process in children?
Thank you for that question. So if I understand correctly, it seems there are two questions here. So the first being how well equipped are health providers in Ghana to identify exposure to risk and psychosocial factors within the home. And then the second is whether there's an issue of overdiagnosis of mental disorders in young children. Is that correct?
Right.
Really great questions. So I'll start with the second one. I actually just came back from a conference of the International Association of Child and Adolescent Psychiatrists and Allied Professions. And sort of the key theme throughout the conference was there aren't enough mental health professionals who are trained in child and adolescent mental health, and there just aren't enough services provided to young children. So within the Ghanaian context, I don't think we have this issue of overdiagnosis, mostly because there just aren't enough services or professionals catering for young children's mental health. So in 2010 and 2014, there are two papers that conducted sort of a systems mapping and analysis of Ghana's mental health services. And there were maybe 3 sentences that talked about child and adolescent mental health services, because they just aren't they aren't existent really in the country. Or if they are, it's really just for a very few proportion of the population. So I don't think overdiagnosis is an issue, mostly because we just don't have enough professionals or services catering for young children's mental health or adolescent mental health at all. And then in terms of the extent to which health providers are equipped to diagnose these, I would say probably to a low extent, primarily because they already have a lot on their plate, right? Medical providers, they're trained in their specific area of specialty. They're trained to focus on one particular aspect. So I don't think they would be the primary delivery agent for an intervention like what we're looking for. I think community health workers and nurses are far more likely to be equipped to be able to, understand what's going on in terms of parents' mental health, understand if the child is being exposed to violence within the home. Then as they spend more time in communities, as they spend more time with families, they're more likely than physicians, for example, to have an understanding of what's going on within the home. And I don't think that's necessarily because of a training gap. It's really more because, each of these individuals are trained to target a specific issue, and they also work in specific contexts, right? So if you're only in your clinic and you only have patients coming to you in your clinic, it's going to be hard to understand what's going on for them in their communities when you don't ever have interactions with them in those communities.
Right, right. And isn't there also like a mental stigma issue where mental health is seen sort of like something that most families don't really want to be associated with, or don't want their children to be associated with? So even if there's a challenge, how easy is it for a health service provider to come forward with that to a parent to say that I think your child needs to be seen for this or that?
Right. So I think Shekhar Saxena, who's the former head of the Department of Mental Health at the World Health Organization, said it best, or says it best, when he says that when it comes to mental health, we're all developing countries. I think mental health stigma is something that, exists in all countries, including in our own communities right here in Canada. And so it's never easy for a health provider to come up to a parent and say, I think your child might be experiencing this issue or that. Within the Ghanaian context, research that has been done around that primarily focuses on the associations between spiritual and mental health. So for a lot of Ghanaians, where about 70% of the population is Christian, about 27% is Muslim, and the remainder are either atheist or practice traditional religions. Mental health is very much seen as being linked to one's spirituality. So if there's usually a concern that someone's experiencing mental health problems, the first person you're going to go to is your pastor or your imam or your traditional healer rather than the mental health professional. And so there's also that aspect of who are people going to for help when they have mental health issues. And I think as researchers, it's important for us to be aware of, within the context where the people that individuals tend to turn to and try to see how we can leverage that trust and those relationships and interventions. In Ghana specifically, there has been issues around prayer camps, which are honestly quite horrific places where people are maltreated in the name of trying to cure their mental health problems. And so it's important in having those in that engagement with religious leaders to be very mindful that people are being treated in humane ways and that you're actually working to address the issue that they have through these different factors that are important to them.
Thank you for that, Dr. Ahan. I think we still have some time to take questions or contributions from the audience.
Of course, if you don't have any questions, we would really encourage you to reach out directly to Marilyn. I'm sure she'd be very happy to provide you with some information in and around her work. And we will send out her email to the members that have participated at this session.
I have my eyes on the chat box waiting.
So if you have no further questions, we'll wrap up the session. We will post the discussion probably in a day or so to our YouTube. If you have any questions or concerns, please let us know at WC Grants. We'd be very happy to hear from you. And of course, if you have any questions about the cluster, please stay behind and we will help navigate those for you.
Great. Well, thank you so much, Dr. Kemia Modu and Michelle and Carrie for having me. It's really been a pleasure.
Thank you, Dr. Ahan.
Thank you all for attending.
Yeah, thank you everyone for coming.
Thank you.